Trouble sitting through a long lecture. And because of that, I'm going to start with my summary slide. And I know many of you came here today hoping that I was going to tell you there was one biomarker you could use to diagnose sepsis in any circumstance that would greatly make your practice more easy. And unfortunately, no such biomarker exists. I want to summarize by saying the diagnosis of sepsis, as my colleagues earlier have been saying, still requires a very high clinical suspicion and your early intervention to effectively treat this disease process and save your patient. In my preparation for this lecture, I researched in the literature and found nearly 200 biomarkers that were listed and investigated for their role in the diagnosis of sepsis in the emergency department. But before we get into that, I want to talk a little bit about what might make a good biomarker. First, a high sensitivity is probably the most important characteristic of any biomarker we may use. Just like in America, in Vietnam, sepsis kills an incredible amount of patients every year. And because of this, we need a test that is very sensitive for ruling out this very morbid process. Beyond that, because sepsis is so frequent, we need a relatively inexpensive test that allows us to run this regularly. We won't hesitate to order this test for fear of how expensive it is. And last but not least, we need a test that's very accessible. By that I mean it provides good, reliable data, it provides rapid results, and it's easy to interpret. So the question remains, is there a role for biomarkers in the emergency department? What role may they play? Can they help us diagnose or rule out sepsis? Can they help determine the etiology of sepsis? May they help guide therapy for certain types of sepsis in the emergency department? And may they help prognosticate who is at risk for poor outcome with sepsis? This won't come as a surprise, but those biomarkers that I'm going to talk about today have been mentioned already. Lactate, procalcitonin, and the last troponin, you may think I'm a bit crazy. There are some future biomarkers coming down the pipeline that still don't have enough evidence to support their use routinely in the emergency department, but I encourage you to read up on them because I think we're getting closer. So let's talk about the first one. Lactate is a byproduct of anaerobic metabolism that is often associated with certain shock states. However, we can find that it also is present in the serum in particular other disease processes, such as diabetic ketoacidosis, certain liver disease, and also when patients are taking certain drugs, such as metformin. We know from an incredible array of literature, and I don't have the time to go through it all today, that lactate is an independent predictor of mortality in patients with sepsis. Okay. Because of that, the Surviving Sepsis Campaign, the Sepsis 3 criteria guidelines, again shows lactate as part of their criteria to define a septic shock. Okay? Despite all the controversy that surrounds the Sepsis 3 guidelines, there is no controversy, I'll say again, there is no controversy with using lactate in a diagnosis of sepsis. In fact, the use of lactate continues to receive significant scientific support, with the most recent publication in the BMJ using a retrospective analysis of 12,000 patients in Great Britain that showed lactate was associated with serum elevation of lactate was associated with poor prognosis and higher mortality rates in these patients. We also know that lactate clearance is associated with improved outcomes. In patients after intervention who have significant clearance of lactate, we know they have improved outcomes. Conversely, a recent study suggested that in patients who fail to clear lactate after their 30 cc's of fluid per kilogram body weight have a lower or a higher mortality rate. So when do we use this? First, obtain a lactate on any patient with suspicion of sepsis. If you use the quick SOFA score or you're still beholden to the systemic inflammatory response syndrome score, I don't care. If you use your clinical judgment, fine. But order a lactate on your patients when you suspect sepsis. Second, make certain that the test is run emergently. By that I mean lactate that sits on a desk in a test tube for more than 15 minutes can give you a false negative or a false positive. So it is extremely important you tell your staff you want that test run right away. Third, if lactate is elevated in a patient, you must suspect a serious systemic infection and you must intervene aggressively and early. By that, I mean aggressive fluid resuscitation. And lastly, after initial fluid resuscitation, make certain that you check for lactate clearance, as it again supports prognosis for patient. Next is a bit more controversial. Dr. Hosfather talked a little bit about procalcitonin, and I'll mention very quickly, this is a propeptide that's triggered by bacterial endotoxin production. In particular, it's attractive because circulating levels peak at around 6 hours, very early in the process of infection, and it's not seen in the setting of other infectious agents, okay, aside from parasitemia. However, some controversy surrounds its use in the emergency department because most data was extracted from ICU-like settings. However, these recent studies I've mentioned here, and you can see in my references at the end, suggest that procalcitonin's use for diagnosis of bacterial sepsis in the emergency department leads to lower mortality. In particular, a Cochrane review in 2018, including 6,700 patients, showed that the use of ordering procalcitonin in the emergency department with admitted patients to an ICU lowered ICU stay, lowered mortality, and improved outcomes, which here is just what Dr. Hosfather was mentioning. So when do we use procalcitonin? Again, I'll emphasize it cannot replace your clinical judgment. Okay? However, if you are concerned, ordering a procalcitonin may assist in the inpatient care of a patient and early initiation of antibiotics as evidenced by the literature I just read. The threshold to exclude sepsis should be under 2 nanograms per milliliter, which has the highest negative predictive value in these studies that I just mentioned. Last but not least, we're going to talk about troponin. And you may think I'm a bit confused because most of you are used to using troponin in the setting of acute coronary syndrome. But I'd like to remind you that serum troponin elevations can happen in any setting of myocardial injury, whether that injury pertains to ischemic events or other etiologies, including sepsis. Also, any elevation of troponin in the serum is universally associated with worse patient outcomes. Troponin elevation is an independent predictor of poor patient prognosis. In a small subset of patients who are suffering from sepsis-induced cardiomyopathy may occur. And this is characterized by left ventricular dysfunction and reduced ejection fraction. It's typically a self-limited syndrome lasting about a week, and in most patients who recover, they recover to full previous ejection fraction levels. We know from these recent studies that these patients also suffer from serum elevation of troponin. In fact, the data was so strong that the American Heart Association, after the first test in 2014, seemed to suggest that initial troponin on admission in septic patients improved mortality. This was confirmed shortly thereafter by a large meta-analysis in 2015 that again reinforced this conclusion. So when do we use a troponin? Any patient with severe sepsis who you're admitting to the hospital should receive a troponin. Troponins predict prognosis. In a patient with an elevated troponin, you should follow this up with both an EKG and a bedside ultrasound. The bedside ultrasound and EKG can help you differentiate as to whether or not the etiology is related to an ischemic event or an infectious etiology. These patients also require aggressive resuscitation after admission. And I would recommend that you still use the cutoff for troponin that you use in the diagnosis of acute coronary syndrome in your institution. So, in conclusion, I'm sorry, biomarkers cannot replace your clinical judgment, but should be used to supplement your clinical judgment in the diagnosis of sepsis. Lactate continues to have the strongest support. Procalcitonin, as well, can be used to lower mortality and predict patients who have bacterial source of sepsis. And troponin can be used as a prognosticator in patients who are admitted to the hospital. in the context of sepsis. These are other, I would say, biomarkers coming down the pipe, however, are not ready for prime time. And I was going to talk a little bit more about them, but I don't think I have time today. And for that, I suppose we can move to questions. Thank you.